The views and opinions expressed on Analyze This are entirely those of the on air participants and do not reflect those of the station's board, management, staff, or underwriters.
And we're back here and Analyze This great first hour, right? And we're looking forward to talking with the Department of Health in hour number 2. And Commissioner Tita is supposed to be joining us live in the studio. We're going to be talking, I don't know if they're on the line yet, with Dr. Ellis and Dr. Hunt Caesar. Let me give you some programming notes for tonight, right? The PBS News Hour, 7 p.m. Recovery and Focus, 8 p.m. Children in Crisis, 9 p.m., right? Explore the journey of a community took to ensure health care for children. That's from 9 to 10. Miss Scarlett and the Duke of Masterpiece. They're from 10 to 11. The story of how Eliza and the Duke meet for the very first time. And then at 11 p.m., Funny Woman. Barbara's life changes overnight. Intoxicated by success, she embarks on a romance with Clive. And of course, at midnight, I'm on Poor and Company. Right? That used to be an 11 o'clock thing, but time turned back. So we do that at midnight. I'm smiling. Something just happened here in the studio. So I'm liking this right off the bat. I thought I'd be talking to her via phone, but she blessed me with her presence here in the studio this morning. So, and she braved the weather conditions and all that. So I'm glad to have a big shot in the studio with me. Well, let me run through that real quick, right? News Hour at 7, Recovery and Focus at 8, Children in Crisis at 9, Miss Scarlett and the Duke on Masterpiece at 10, Funny Woman at 11, I'm Important Company at midnight. So they told me that the Queen Bee on St. Croix, right? Right. Well, a Queen Bee, because we got multiple Queen Bees at Department of Health, was going to be joining me via the phone. So I was like, it's not like her. She normally likes to get in here and have that face-to-face discussion and just let me know what's going on in the Department of Health. And then, of course, the Commissioner Tita Encarnacion is supposed to be joining us at about 9:20 because she has some running she's dealing with. They also told me another Queen Bee out of St. Thomas is going to be joining me on the line. And like I mentioned earlier, when we first started the gig, right, on April 27th, day 2, April 28th, Department of Health, they made some time to join us. Of course, we were in the throes of the pandemic, the early days. Zombieville was alive and well, and they helped validate our existence, and since then we've been on a roll. So let me introduce the one and only Esther Ellis, Virgin Islands epidemiologist, public health guru, and all that good stuff to the studio. Good morning, Dr. Ellis. Glad to see you.
And so great to be here. Wonderful to be here. The weather was so nice outside. I decided to just walk over.
Happy New Year to you, man.
Happy New
I
Year.
know it'll be February in another 5 or 6 days, or another week, because today is the 25th. So.
Well, this is my second appearance for 2024, so I feel very blessed to get to be here again in January of 2024.
Your family, so it's all good. and I believe we have Dr. Tai Camille Hunt Caesar joining us from the RAC. Good morning, Madam Medical Director. How are you?
Good morning. How are you?
I'm good, Madam Founding Dean and all that good stuff at UVA Med School. You good? Everybody good?
Yes, sir. Everyone's great.
Okay, good. And the commissioner's going to be joining us in a little bit, right?
Correct.
So, let me start over there and then come back to you. Dr. Hunt Caesar, good morning once again. What's the state of public health in the Virgin Islands as a medical director, from the medical director's perspective?
That's a loaded question. You want to talk about public health,
analyze this.
That's large.
Analyze this. We do it like that. You know what I'm saying? Because you can handle it. Talk about where we at right now. It's January. I took my mom's for a flu shot yesterday. So, that's what we're dealing with. Talk to me.
Yeah, right. So, I mean, if you want to talk about public health, we get into all of the chronic diseases that really put us in a really debilitating, state in the territory as it relates to healthcare. But we are here because it's respiratory illness season in the winter months. So that is that's where we are, and I don't think we are necessarily in a bad place. I think that it's very similar to previous respiratory illness seasons, taking out the confounding COVID-19 pandemic. So we're seeing circulating viruses. It's not something that I think that is out of the ordinary from what we're used to seeing. I think that the public has been so sensitized to respiratory illnesses because of the COVID pandemic that we talk about it more, which is not a bad thing, because in the infectious disease community and the medical community has been forever trying to get people to respect what respiratory viruses can do to the human body, and warning against the unfortunate consequences of pandemic illnesses that we, of course, were thinking all along that it would be pandemic influenza, but we were crippled by a novel other virus, a coronavirus, which is why it's extremely important for the public to understand that when we talk about respiratory viruses and illnesses, we have to understand that it's not always going to be COVID, it's not always going to be influenza, but there are other viruses that circulate that can be just as harmful, that we all need to be cognizant about and just have respect for these viruses and be as smart as we can during the peak season for these viruses.
Okay, Dr. Ellis, as our epidemiologist, give me some data, because I know that's what you're good at and what the public would like to know, so that they could mentally process where we're at and
right.
The kind of protections that we need to put in place personally, for family, and the community at large.
Right. Our numbers are low, which is really great. So far, January 2024, we've seen 7 reported flu cases. In January of last year, 2023, there were 6 total reported for January. So this is about what we see. January usually isn't our peak month. Our flu season here is usually a little bit delayed because all the travelers are coming in here in
Correct.
January and February, and then we have a delayed flu season a little bit after the holidays. So we're not seeing any kind of spike in cases yet. We're also not seeing a spike in COVID post-carnival, which is great. In our COVID report that we just released, there were 32 new cases last week. 6 of those were on St. Croix, and 26 of those were on St. Thomas, and 0 on St. John.
Now, it's my understanding that I was talking to one of my friends, and he said he had just passed the emergency room about 3 weeks ago, right after we had our festival village. So you're saying that was not necessarily COVID dominant. It could have been other viruses as well?
Not necessarily. Yeah, it could have been other viruses. It could have been COVID that someone did a home test and never got reported to us. So that's possible. But we do believe that we're capturing enough cases right now to still capture the trend, because there are still people coming to Department of Health. We have free testing from 9:30 to 10:30. They're coming to get tested. A lot of people that come to get tested already know that they're positive. They did a home test that was positive, but they need that positive result confirmed so that they can qualify for Paxlovid or any of the other therapeutics that are available at the time. And so if you do test positive at home, it is important that you get a confirmatory test from a laboratory or the Department of Health. The test of the Department of Health is 100% free. We're open from 9:30 to 10:30 for that free test, and it's in the health van. The health van on St. Croix is located in front of the red modulars that are by the old Charles Harwood building, and the health van on St. Thomas is located at the loading dock of Schneider Regional Medical Center, and on St. John, we're there every Wednesday providing testing at the Vipa Gravel lot. And also Myra Keating, if it's not a Wednesday and you're on St. John, you need to get tested, you can go to Myra Keating.
Dr. Hunt Caesar, what was the RSV infection? What is it? And what would be symptoms?
So the respiratory syncytial virus is another respiratory virus that typically and commonly what we have been always focusing on can be really detrimental to infants who are under the age of 2 or even under the age of 5. They can get really, really awful respiratory infections called bronchiolitis, and it can cause them to have to be in the hospital. And sometimes, unfortunately, this can be very bad, where it can be fatal. So the children, especially who are premature or who have heart conditions that they are born with, they are most at risk for having really bad complications with the respiratory syncytial virus, or RSV. But just like how it can be bad in this population, it's very contagious, and so other people can get the infection. It's not age discriminate, but it usually is not as bad in the sort of like the non-infant and non-elderly population. So babies and children can spread it to their grandparents who have underlying chronic diseases and can have really, really bad symptoms as well. And it's very similar to the flu and COVID, where you'll have cough, fever, shortness of breath. And like all of the viruses that you can get over, sometimes, unfortunately, you can have complications after you get a viral infection that can lead to things like pneumonia. So that's why it's very important that we now have a vaccine against RSV that has been approved for individuals over the age of 60. So that's the newest thing that we should start to become protected against. We need to be protected against the things that we can, especially in the elderly population that can start to have bad complications like we've seen with COVID and influenza over the years.
Dr. Ellis, the most recent variant, COVID variant, is the JN1. JN.1. Have we seen any in the territory?
That I'm not sure. I would need to check with the lab.
We have the ability to test for that?
We have been sending samples for sequencing.
Okay.
So we actually send our samples out of the territory for sequencing right now, but we're working to build our local sequencing capacity as well. And I know you also asked about what were some of the other illnesses that we saw post-carnival. We did see a small spike in norovirus. That's really kind of like I guess you would call the layman's term a stomach bug. Mm-hmm. But we did see some cases that causes very quick onset of vomiting, followed by diarrhea and sometimes chills with a low-grade fever. Okay.
Now, Dr. Hunt-Caesar mentioned bronchiolitis. That's what she said. With respect to RSV with children, what have you. We're hearing a lot of discussion now about long COVID, right? If you can define what long COVID means, and then every time you're hearing somebody may have a health issue, people are saying, "Oh, the vaccine caused that," what have you. And in doing my reading, doing my research, and talking with my friend Dwayne Henry, who was there with y'all at the inception, long COVID and the effects of having COVID down the road. People tend to take that for granted, but that's a real deal, isn't it, Dr. Ellis and then Dr. Hunt-Caesar?
Yeah, and I'll definitely pass that to our medical director, Dr. Ty Hunt-Caesar, because she'd be the best person to speak to about the medical ramifications of long COVID. But from an epi side, quick before we go over to her, we are working with the Disparities Group to do a study on long COVID in the U.S. Virgin Islands to determine, how has our population been affected by long COVID. It's difficult to do because a lot of individuals that have long COVID aren't necessarily seeking care, which we really want to know about too, because that's a health equity issue. And so reaching out to probably everybody that had COVID that we know about, and then understanding how do you feel now. And we have a questionnaire that we're working on developing, and we'll be deploying that within the community shortly.
Good. Dr. Hunt-Caesar, the floor is yours. What is long COVID? What is long COVID, and what are we seeing as it relates to impact?
So and there's so much I can talk to about long COVID. It's really fascinating, and it's not necessarily unique to the COVID-19 virus, because there's so many other viruses where you can have long-term complications. So this is something that infectious disease physicians love to investigate and try to encourage people to prevent yourself from getting these infections because of the bad things that can happen long term. And then it goes into the other areas and other specialties in which you have these symptoms, because it's not because you have the virus that is persisting in your body for a long time. It's actually the body's response, like your immune response. So, and all of the various systems that it impacts. So what is long COVID? Long COVID is actually defined after, I think the definition may change, as we learn more, because we're still learning and we're still gathering information. But we do have a definition that says that this is going to be the persistence of symptoms that you had because of a COVID infection that persists and lasts longer than 12 weeks after the initial infection. That's really important, because sometimes someone can get, an infection, and then it will be, people want to get better fast, right? So a week afterwards, you're like, well, I'm out of quarantine, and I still ain't feeling good, and I still coughing. Okay, well, that's because, that's a normal response to a post-viral response. You might cough for a few weeks. But if you are coughing, if you are having shortness of breath, if you are having fatigue that's lasting longer than 3 months after your initial infection, then you're probably exhibiting symptoms or manifestations of the long COVID syndrome. And that can be those, like just the symptoms of what you had. It could be that you can't smell. It can be that you've lost your sense of taste, or food is just really tasting bad. This can happen for like months after, up to a year after. It can be something as dramatic as an arrhythmia or a heart condition. Okay, there's something that can be really serious, in which you can't really walk around, and your activity is restricted, is limited, because of the effects that it had on your heart cells. It could be that you're not focusing as normal as you were. You're not remembering things the way that you are, because the virus can affect all of the systems in your body. And again, it's important to understand that people want to blame the vaccine, but really and truly, what the evidence and the data and the science is showing is that these symptoms and these
events,
these events that are occurring is really because of a naturally occurring infection. Okay, and we've seen that, we've documented that with other viruses as well.
So I'm gonna stop you right there. Because we're gonna take a break. We got the Department of Health joining us, family. Come back home. They've been away for a while, but we're glad to have them in the studio and online. I think we're gonna be joined by the commissioner in a little bit. We have an obligation to update the public as to where we are from a public health perspective, and we're looking forward to having more of this discussion. Be back right after this. And we're back here on Analyze This, and we have been joined by the shot caller, you know what I'm saying? Madam Commissioner Tita Encarnacion. Good morning, Commissioner. Glad to have you in the studio.
Good morning. It's always a pleasure to be here.
Without a doubt. And we were talking about long COVID and how we're learning, which brings me to something. Good morning once again, Dr. Hunt Caesar. Glad to have you here this morning. When I asked that question, I heard you using the term fascinating, and Dr. Ellis said something along the same lines. I get the impression that this is very much a learning experience for even the medical professionals like yourself. Explain to the public why you would use the term fascinating, because I believe I know what the answer is, but I want to hear it from you as it relates to where we were 4 years ago and where we are now. I want all three of you to speak on this. I'll start with you, Dr. Hunt Caesar.
Well, I use the word fascinating when I was describing how you can have examples of an event that happens that you think, okay, well, once you get over the event, that's it. Some people experience that, and then you have a whole subset of individuals who have all these kind of chronic symptoms, and they're so convinced that it's because they still have that event happening and it's ongoing, and it's not. We've seen this with Lyme's disease. We see this with sometimes the influenza virus. We've seen this with many different other viruses. We've seen this with chikungunya. We've seen this with all types of many, and not even just like viruses in the same family. Many different viruses that happen that cause different problems that come from different genuses and species. But yet, what happens is you have your body responding, the immunologic response that your body launches, and it causes all kinds of different things for long periods of time. And it doesn't have anything to do with the virus or the bacteria that initially had the problem. And then you're going to have to spill over to the other specialties like the rheumatologist, the cardiologist, the neurologist, to have to treat those symptoms. But immunology should be able to help, and we need to do more research on that to see how can we address the immune response that can sometimes be enhanced or stronger or more bothersome in some individuals. So it's fascinating how one thing can lead to another, and it doesn't have to do anything with the individual organism. So I just think it's fascinating, and we just always have to work together with all the internal medicine professionals. We come together to try to help as best as possible, but it sometimes is not just one person.
Commissioner, talk about that learning dynamic and how we're literally, and from an educational standpoint and science, better off today than we were 4 years ago.
Well, before I do that, I'd like to challenge Dr. Hunt Caesar a little bit, because one of the things that you said, Dr. Hunt Caesar, is that it's not linked or it's not associated with the initial virus or whatever that species is. However, it is as a result of it. So there's a link to that. And a lot of the public health officials that I meet with on a weekly basis are actually in a quandary to actually explain the concept of long COVID, because there's so many other comorbidities now and symptoms that can be linked with long COVID. It's very difficult to define. And that's one of the things when you're looking at insurance companies, when you're looking at the care that's actually being provided, how do you care for someone that you cannot define or describe the linkage between one and the next?
Yes. So it absolutely is a cause and effect situation, which is why it's so important to underscore what prevention is about. And when you talk about some of the symptoms of like long COVID and some of the things that spill over, I mean, it's so important there's so many things, right? It could be just, we're talking about symptoms, but one of the biggest impacts that COVID-19 has had on the people that it's affected is the unmasking and the link and association that it has to diabetes. Mm-hmm. And we have seen that is absolutely something that has been a major problem and concern in individuals who were already predisposed to diabetes. What it has done to the insulin receptors and the pancreas, after someone who's been infected. And then, so we're seeing more diabetes now, and mm-hmm. we already have more than the national average of diabetes rates in the territory, and we have so much complications and things that happen to our territory with diabetes. So
we're also seeing autoimmune changes that we did not see before, and that Absolutely. Could be linked with COVID-19 mm-hmm. as well. Autoimmune changes. We are actually seeing a lot of more asthmatics, cardiac anomalies, especially in the teenage population. That's one of the reasons why we stopped Johnson & Johnson. And so there's so many different things. So that was actually attributed to the vaccine. However, a lot of what we're seeing is attributed to the virus itself, because look at it, it mutated so many times. The things that we are experiencing in our bodies is an effect of what the changes that we're seeing with the virus itself. So, and you speak, Senator, about the education, and this is all we're speaking about, right? The educational aspect of COVID-19. Mm-hmm. The individuals need to know that, having COVID-19 may not, and some of the symptoms, the taste, let me just talk about the taste. Some people lost their ability to taste and smell for days, some for weeks, and sometimes actually for a couple of years. So, and that's something that I have to tell you that one time I said, okay, well, it's just taste. It's not just taste. It actually affects the mentee as well. So there are a lot of emotional changes that can occur.
Dr. Ellis, I had COVID before we had documented COVID in the territory. January 2020, thought I had the flu. Didn't realize that it was COVID until like 2-3 months later. And the reason why I know it was COVID, because there's certain things you can go to when you get back your appetite, right? And when I bit in my tuna fish sandwich, it tastes like rubber. I'm telling you, mm-hmm. right? Yeah. Now, this doesn't mean that your agency was wrong. It just means that, from a knowledgeable standpoint, what we knew, what we didn't know, looking backwards.
Our agency is never wrong.
Our first case was in March.
No, you're right. Just from a documented and technical perspective, mm-hmm. the first COVID was March 13th, right? Of 2020. That's D-Day, D-Day in Virgin Islands. Like when we were stormed at Normandy Beach, right? It was November. It was March 13th. It was Friday, March 13th.
I remember exactly where I was.
Friday, March 13th, and he said, "Oh my God, it's here." You know what I'm saying? But so we start this program like a month and a half later, and one of the things Ronnie Russell said, he said, Neville, we've been getting immunization shots all our life, mm-hmm. right? We'd line up at school when public health would show up. We never questioned it then. They questioned this one because of how fast they claimed the vaccine. It took to develop the vaccine. Mm-hmm. But in talking with Dwayne Henry, and I like to read. Mm-hmm. This actually started back with SARS, didn't it? In 2002?
Actually, back with HIV. So if you look back
HIV,
at the vaccine. So,
wow.
I mean, when you said, is this fascinating? The vaccine is really fascinating to me, mm-hmm. the technology. And it's incredible that we were able to use technology that had been researched for the past 20 years in trying to develop a vaccine for HIV, mm-hmm. and the mRNA spike protein approach, and quickly pivot that to, okay, we can use that same technology that we know can work to fight this particular virus, and it's been incredibly successful and saved who knows how many lives, but at least millions of lives.
No, the thinking, Dr. Huntsy's, and by the way, Christine Letton has joined us here. She's hanging out on the couch, just processing everything, and we'll get the news release down the road. Dr. Huntsy's, the belief early on was you get the vaccine, your body building up. What was the term? The defense mechanism. What was it? Immunity. We don't want to use immunity. Sounds like a.
So I mean, I think of it as a map. It gives your body a map to understand how to get to fighting off the virus faster. That's really kind of, it primes your immune system so that when your immune system does come into contact with the virus, you're able to fight it faster and not get as sick.
I like that. No, there are those, Dr. Huntsy's, who believe in natural, right, immunity without the assistance of vaccine and all that stuff. Explain the distinction there. 'Cause there are those who have never taken the vaccine. They may have been infected, and they believe that their body now is better off because they survived a COVID-19 infection. How do we, mentally process all that? And I want the public to know that I respect everybody's position. We're not forcing anybody to take anything. I think that's very, very important. But some of us are, embrace the science. Others, they say no. So, but talk a little bit about that combination. Like for myself, right? I got the series. I got a couple boosters. I had COVID, so I believe I got this combination for a race of immunity inside of me in order to fight off this thing. But how do we really, process and legislate all of this from an educational standpoint?
Okay, so if you believe in prevention or treatment. So that's pretty much the difference between the vaccine and waiting for a natural sort of response, because the vaccine is something that primes your system and puts the antibodies in place so that it's there. And when it sees the virus, while you might get symptoms, it'll start to attack that virus and really get you better a lot quicker and protect your body from the really, really, really awful or detrimental effects that might happen afterwards. Remember, this was a novel virus, okay? What does that mean? Novel means that it was never introduced to the human host, the human body ever. So take that into consideration when you're talking about the regular common rhinovirus cold, okay? You can get a cold over and over and over again, and your body gets you kind of feel yucky. You get better in 1 to 3 days, okay? But this was something that was novel, that the body has never seen before, meaning that if you were exposed to this virus, your body, first of all, got so sick because they had never seen this before, and it was doing its best to, number one, get rid of the virus. So it's fighting to try to stop the body from feeling sick. But because the reason why, another reason why people really got ill and some died is because the immune response was so severe and so massive that it was like a surge in the bloodstream in your body that the body really couldn't even handle. So take that into consideration, where if you, so say you wanted to, I just want the natural response. Well, your natural response without actually having a vaccine or a vaccine response, an initial, and the antibodies already there, is real risky, because you don't know how your body is going to respond. You don't know if it's strong enough. And then everyone, will want to think, I'm taking immune boosters. That does not have anything to do with anything, because the COVID virus is something so unique, to the human body, that no matter what you could do, no matter how strong you think your immune system is, your immune system may not have been ready to actually overcome that infection and get you through it.
Because of the novel nature is what you're talking about, right?
Because of the novel nature, which is why the vaccine was so important, to prime the body to prevent it. Now we 5 years out, right? Which I'm glad you went there, because that gonna be the segue. That gonna be a segue to the question I want to ask the commissioner. Commish, are we gonna get federal funding to do the VI study as it relates to how we dealt
with the pandemic and COVID-19? Have you heard anything?
Not necessarily in reference to that. I know that we're doing a lot of health equity work, and so that will lead us to being applicable to being able to get some funding. We actually are in the process.
Isn't a study necessary
Well, I
from a
think
public
that
from a public health perspective, so that we
from
could?
an epidemiologist standpoint,
Okay.
yes, for sure, but it's also important for us to tell our story. And so, yes, we are. I think we have all the data that's needed within the Department of Health. And so we've spoken about this, but putting it in writing, and the governor has asked us to do that as well. So tell the story about what happened here within a territory, and be able to keep that to us, so that we can actually compare it if something else happens, God forbid.
Yeah.
Well, and Dr. Ellis, we had a variable here, a dynamic here, where we became a vaccination destination early
Yeah,
on. So
yeah.
I think that
Vaccine
story
tourism.
alone by itself, where you had folks who didn't live here but were vacationing here, were lining up, and knowing that at 3:30, 4 o'clock every afternoon there were vaccine doses.
Well, I think that actually Director Harris and I were talking about that just a couple of days ago. And the way that we managed COVID was the vaccines, was making vaccines accessible. But also we did so much more than that. We actually got out there. We were in the project areas, and we were talking to the people face to face. So really,
No, but I want to talk about your agency. Okay, your agency was doing a brilliant job. I'm talking about the public being aware of what was available. And
True.
folks hopping on plane. They
And
said,
it-
I could get two birds with one stone. I could get sun and
Yeah.
sand and a vaccination.
and
a
we were
vaccine.
able to do that because of the boots on the ground process as well.
Oh, without a
Look
doubt.
at what we did with the BVI.
Oh,
the
yes.
BVI
No,
actually
we
came.
we spoke about that 2 weeks ago.
Yeah,
You
we
know,
managed it
Delta.
by
That was during
the
the Delta,
correct.
in
And
2021.
they did not have the types of vaccine that they felt they needed. So
So the UV,
Reach out.
so USVI save the BVI? No,
we never do that. We never say we saved them. We collaborated
Right.
with them,
Helped.
and we helped them.
Help them?
Correct. And
Okay.
I have to tell you that the
Can,
former minister.
we don't like to give ourselves our flowers. We wait till after the fact, you know. So that's the reason why I'll take a break. The conversation getting good. When we come back, we'll pick it up there. We'll also talk about
Okay.
the media,
But we
right?
did,
The
we
press
did give
releases
them
and all that
testing
stuff.
supplies, so.
Everything, yeah.
We'll be
Actually, we
back.
send folks over
Yes,
there.
and train
That's
them
right.
on how to
Be
do
back.
the testing.
Be back right
and
after
the
that.
reporting.
Right after
Yes.
this.
Okay.
And we're back here, Analyzers, having an awesome discussion, learning as we go with the Virgin Islands Department of Health. I do a quorum call with the table talk, so I can do a quorum call with all three, and I can do it in alphabetical order. We're gonna start with Dr. Esther Ellis. Good morning, Dr. Esther Ellis. How are you?
Good morning.
Good.
Wonderful.
Good. And then we got Tita Encarnacion, Justa, Tita Encarnacion.
Good morning, and good morning to the audience.
Esther St. Peter's up there. And then Dr. Ty Camille Hunt Caesar. Dr. Hunt, how are you? Dr. Hunt, you there? Look like we lose Dr. Hunt Caesar.
No, I'm here. Sorry, I was on mute.
Sorry. Had me panicking there for
Good, thanks.
No, did I? And
No panic.
And they're being policed this morning by Christine Lett. You know what I'm saying? She's making sure everybody says the right things and all that good stuff. So we're good. So, first of all, there's been some press releases. What you said? Vital what? Vital stats?
Vital stats.
The vital stats.
Records,
The Virgin Islands Department of Health Office of Vital Records and Stats going fully digital in 2024. So we're taking the next step, Commish?
Yeah, that's something
Big step.
Yeah, big step. I have to tell you that we're one of two jurisdictions who have not been digital for vital stats, and so it's really huge that we're able to do this. So I really want to commend Dr. Lorraine Benjamin Matthew and her team for making this happen. It was one of the first things that I put in front of her as a challenge, and as well as something that we know the governor and digitalization is one of his primary goals, and so we wanted to make this happen. And in March, we should have, we actually started in December, where the educational process and the implementation started. So it'll be fully open to the community in March of this year as well.
No. To me, the world is we're in full analytical mode. We got to show them analyze this and all that stuff. Back in 1993, so I was born in New York City. So I reached out to the Office of Vital Statistics. I said, look, I need a brand new copy of my board paper. They hooked me up in no time. I want to do it now. I got to go through all kind of technological computer this and I need a copy of my board paper, man. I mean, this
They hooked you up in no time?
In no time. And this is 1993. This is pre-internet. Internet is 1994. They sent me my green board paper.
And that was probably because you knew somebody.
No, I at the time I was working in education, and I said, something, I need a copy of my board paper, and I had it, and then you fold it up, and you keep it full for too long, and then the crease them start to break, and then they tear apart.
Yeah.
You know what I'm saying? So we need help. For those of us, remember now, Tita, you know about this, right? And for those who are listening, we keep talking about the Great Migration that lasted 60, 70 years. Virgin Islanders who moved to New York City, right? We need some kind of linkage to help us, all of us who born in Brooklyn, Harlem, the Bronx, wherever, that we could get a board paper. We need a board paper, man.
I have to tell you something that I called Director Matthew just yesterday. We're looking for a birth. We're looking for death, actually. And she was able to go online right there and access the information that we needed. But I can tell you that what we're doing right now with VitalStat allows us to begin the HIE process. We're talking about health information exchange for many years.
This is music to my ears. Right. Health information exchange. That's what I want.
So this gives us the ability to store information, pull information, and share information.
Okay, that's good. So at least I know that is taking place. Dr. Ellis, one of the things that you did early on was you kept talking about the EPI team, right? How's the EPI team doing? This was something that was, you always mentioned this when you came on because y'all was inundated with a lot of responsibility, a lot of work. Dr. Hunt Caesar talks about the novel nature of this virus. A lot of us were in panic mode. Anytime we heard somebody may have had it, we were wondering about proximity, all that stuff. How's the EPI team doing?
They're great. We love to work hard because we've been working hard on lead. So and we really never stop. There's always something to do in the community when it comes to epidemiology and prevention. I know we spoke earlier about long COVID and working with the Disparities Group on doing a study on long COVID. So there's always, even if you don't hear about it right away, there's things in the background that we're doing. We like to work hard and have fun. So right now we're moving over to St. Thomas, St. John. We're expanding the pediatric lead screening and in a continuing effort to really develop a baseline of exposure for children 6 and under, which is the most vulnerable population for lead exposure. And pediatric lead screening is going to be provided there at no cost. Parental consent is required before the test can be administered. So we'll be going into the schools starting on Monday. On St. Croix, we tested over 1,270 children. And we did find 3 positives that were confirmed through a venous blood draw that had lead in their blood. And we did home assessments at those homes, and we did find lead in cooking pots, commonly used cooking pots, and tile flooring, where the children played a lot. And so the most important thing when you do identify lead in the blood of a child is, 1, identify the source so you can remove it from the household so they're no longer being exposed to lead, and also get them into care. And so those 2 things were accomplished, and we will be retesting. Then you retest 1 to 3 months later to see if those lead levels have now gone down to undetectable.
Subsided, right? Or what's the term? Abated.
Decrease.
A decrease, abated, right?
Well, decrease, because and we wanted it to be 0, but like Dr. Ellis says, you really have to take that source away. Now, one of the other things that we're doing is that we're speaking with Dr. Hunt Caesar, is speaking with the private pediatricians, the practitioners in the federally qualified health centers as well, so that we could continue the testing. It's not just starting it, but it's actually being consistent. I always believe that consistency is actually what produces success. Mm-hmm. And we're also working with the Senate to ensure that we have acts in place that mandates all practitioners to report to the Department of Health any increase in that level, so that we could continue doing the tracking, go into the homes, test not only the water, but like Dr. Ellis says, the substances that are around that may be affecting that as well. And you know what, we're speaking about patients 0 to 6, but we also have to speak about the pregnant woman and how that may affect them. And so right now, the practice is that, give me the numbers, Dr. Hunt Caesar, in terms of the percentage of population that we are, 30% is what we're really looking at. But in terms of the age group that we'll be testing on an annual basis, I think it's 6 months, six months to
9 months to 12 months. 9 months to a year is when we should have children routinely being tested and screened for lead.
And then we'll also be testing all of the Head Start children. Mm-hmm. And that gives us the continuous idea of what's happening. So we worked very closely with DPNR and WAPA on a regular basis to ensure that the numbers that we're looking at was consistent. Because to say that we have high levels of lead in the water, because that's what we thought at first, it proved differently when we started to test the children as well. And then, of course, that was validated when the retesting of the water was done. So we were able to compare what we're doing from a clinical and a technical standpoint.
Now, Dr. Hunt Caesar, numbers, right? You know, that's something that I enjoy delving into. And I remember our very first show, I think it was Esther and Tita at that point. First name basis, forgive me, but that's just how it is right now. Okay. And I think it was Tita who said, we knew that St. Thomas, Charlotte, Mali would be more susceptible to infections because of population density, right?
We spoke of that.
We spoke of that, right? Mm-hmm. Early on, right? So numbers, mm-hmm. right? Mm-hmm. Again, now the numbers. Dr. Ellis, did you not just say that 0 positives in St. John?
For COVID right now.
For COVID.
Yes.
And Dr. Hunt Caesar, isn't St. John the highest percentage of our population that are vaccinated?
Correct.
Mm-hmm.
The numbers, I mean,
Yep.
It's not perfect. They don't tell the whole story, mm-hmm. but they don't lie, mm-hmm. right? There's a reason why we must embrace the math and must embrace the science. Dr. Hunt Caesar and then Esther Ellis, your take on why we should encourage the public to embrace the science.
Well, I mean,
not just because your parents pay a lot of money to send you to college, right?
You're speaking to a scientist, so of course they're going to be like, embrace the science.
Especially one that specializes in that area.
Yeah. So I mean, I am, as a medical provider and as a student of medicine and a student of public health, we're trained to understand and practice what we call evidence-based medicine. So we don't do things just because it's anecdotal or because it's supposed to work. It's actually something that that the field works together with researchers and clinicians together to ensure that what we think and what should work in theory actually does work with proven research and in the field and with clinical trials. And that's what the process that we've used for all things, all medicines, all what we consider Western medicine, to come up with for clinical practice. And what I always like to try to talk to our audience and our public, our community members who try to sometimes reject, Western medicine. It's not something that we should. If you are a naturalist or if you want to embrace natural techniques, these are things that are studied as well. Some of the most highly effective treatments for infections, like really bad infections like malaria, are like Chinese root based. Okay, that have been proven effective, and this is what we actually use to actually treat bad diseases. So it's not something that people think that, like, oh, vaccines are bad and they have all these bad things in it. These are things that we actually study from the naturally occurring elements that are in the environment, and we study them. And just because it's studied and it's actually proven and it's commercialized to be used doesn't mean that it's something that is not natural or it's against what we are considered natural medicine. And the two don't are not, like, mutually exclusive. It's not independent. It's something that we should continue to use together, especially in the form of the preventative from prevention, which is one of our main themes in public health.
And Dr. Ellis, I learned this word efficacy, right? and Dr. Bronco Hendricks actually had to reach out to me so I could pronounce it correctly. Did I pronounce it correctly?
Yes, you did. Yeah.
And that's what we're talking about, isn't it? Looking for a desired result, but we're doing that based on data or data, depending on what.
Exactly. And so, I mean, what I do really is data-driven decision-making. And as the epidemiology division, we're responsible for collecting the data, storing it, sharing it with the public. And so a lot of what EPI and the states and as well as here is moving towards are called data dashboards, so that everybody can see the data in real time. We do have a COVID data dashboard that's going to be released soon, so that it's just as soon as tests are done and positives come in or negatives, it's you just go to the website and you see exactly what's happening. Same with flu, same with RSV, and it's just making the data publicly accessible as well, instead of releasing weekly reports or various intervals. The public can see and be involved in part of that decision as well.
Tita, I want to ask you this question though, before you respond there. What was it about what we were doing that by May of 2020, we were in some instances not suffering from COVID? I know we had the lockdown and all that stuff, but we really did a good job in that first 6-7 weeks.
I think that one of the things that we did is through the governor's office or the task force. So we met daily, so everyone knew what was going on. So tourism was on the call, education was on the call. So we were speaking to each other on a daily basis, and we were preparing each other. We were tracking, looking at data again. What was happening in Europe and in other parts of the world? What was happening in the mainland? Because we know it trickles down here. It trickled down to Puerto Rico, then it came to us. So we were able to plan. We were able to make decisions, and to me, in a way that prevented more deaths, because our projection was high. Like the governor said,
they had us later on that year at suffering big time between September and December of 2020.
It was numbers that scared us. Yeah. but it didn't stop us.
Yeah.
Because if we were paralyzed by what we were hearing, then we would not have been successful.
But it goes to show, right? Not all models. It is not one size fit
Correct.
all.
Yeah.
Because half the population separated by water.
Right.
You know what I'm saying? So they were just thinking of applying
And
that.
in the end, we had the third lowest death rate, which
Of
is
course.
incredible.
Right.
Yeah,
and
man.
part of what makes living here and being here so unique and wonderful is our connection to each other
Mm-hmm.
and our deep-rooted kind of community sense. And so because of that, we had access to monoclonal antibody therapy. We had access to the Paxlovid, whatever therapy was working at the time. We actually were recognized in getting that out to the community faster than other states were doing because
I think our numbers are the number of people we have within the territory assisted as well. And I have to tell you that Dr. Hunt Caesar played a major role in that. And I want to give kudos also to the communicable disease team that was out there on a daily basis, along with EPI.
I
to ensure.
am so upset that we didn't do the hour and a half like we normally used to do. But
Time is going.
come back again before the fear.
Okay.
Okay? Thank you, Dr. Hunt Caesar. Great contribution this morning. Thank you, Dr. Esther Ellis. She's a crucial now.
my pleasure.
Christine Lett, thanks for being the police, keeping us together. And Tita, always good to see you, okay?
Always good to be here.
Enjoy the day for the rest of the day. Be good and be safe. Talk to you soon. Bye-bye.
Thank you.
Bye-bye.
You got it.